Hi, welcome back to the podcast, Can Silicon Valley Save Healthcare? The podcast where healthcare leaders talk about technology, technology leaders talk about healthcare, investors talk about impact, patients have a voice, and everyone has an opinion. Today, we're very lucky to have Nancy Brown from Oak HCFT on the program. Nancy, welcome to the podcast.
Well, Adam, thanks for having me. This is so exciting. I'm happy to be here.
Well, we're thrilled to have you as well. And I got an opportunity to see one of the panels that you hosted down at Vive, and we'll get into that in a little bit. But why don't you tell us a little bit about yourself and your background? Because when you look into Nancy Brown's background, you've had a lot of experiences.
Well, that's because I'm old. That's what I tell people. I've been around a long time.
That means I'm old too. So
yes, and when we get into the questions about whether healthcare is broken and what we've done to help it, I'll give you the punchline already that I haven't had enough time to fix everything or to begin to fix everything. Anyway, so my background, 30 plus years in healthcare. I'm going with 30 plus without any specific details of actually how many years. I got out of business school and went right into healthcare, which was highly unusual back in the day. So I started in a Kaiser-like model here in Boston that doesn't exist anymore, but it was called Harvard Community Health Plan, which meant we had about 1 million members and we provided all their care. So during the day, I ran clinics, which I loved, big multi-specialty clinics. And at night, I did clinical process reengineering with people like Don Berwick, who at the time was a pediatrician. He still is a pediatrician, but he was just starting on his quality journey. And so we got to really think about all the care that needed to be delivered to our 1 million members and think about it very specifically. And I'm sure I will talk more about that later. But that led me, to make a very long story short, it led me to become an entrepreneur eventually, to leave nonprofit and to work on the development of technology to support the point of service. So it turned out we came up with all these great processes and we needed technology. And this was before, it's going to be hard for some of your listeners to believe, but before the internet was available to citizens, or I like to say before Al Gore invented it, and there was no graphical user interface. We had to use Macs. So there wasn't, so this was a long time ago. Epic was a scheduling system. Cerner was a lab system, and there wasn't really anything. So I branched out and got my first experience with Silicon Valley and had 3 venture-backed companies. 2 of them were bought by McKesson, and the one in the middle was Athena Health, where I spent 6 years, 3 years before we went public, 3 years after. And then the woman who was responsible for the lead investment at Athena is Annie Lamont, who I work for now. So anyone who's trying to connect all the dots. So 8 years ago, I crossed over from being an operator to being an investor. Fantastic decision. And so I've been at Oak HCFT for 8 years.
Wonderful. Tell us a little bit about Oak. What makes it special? Other than the fact that you're there.
This is it's like being, whenever I'm asked to talk about my company or my company or the companies we invest in, it's like being asked to talk about your children. You're like, let me tell you what. Let me tell you.
Let me tell you.
So, I got to know Oak as the entrepreneur who had Annie Lamont and Andrew Adams sitting on our board at Athena. And I got to see what, value-added investors look like. So I would love to tell you that was a clear path. Everything at Athena was perfectly laid out and ready for the IPO, but that would not be true. It was just like any other company that had ups and downs and circuitous routes to success. And they were just nothing but value-added, always there to help, never there to second guess. Bringing valuable resources. So when they decided to spin out of Oak Investment Partners and create Oak HCFT, I came in as the first employee with absolute clarity that this would be a value-added firm. And what that specifically means is that, of course, we lend money or we provide money to our portfolio companies. But even more so, and I think hopefully Syllable feels this way, that what we're really doing is lending our expertise. So healthcare expertise in the form of scaling and growing companies, connections to payers, providers, pharma, employers, talent. We have a whole talent team that comes in and helps provide support in hiring, and we have a tech team that comes in and supports. So that's what we do all day long. I think we're the largest sort of focused healthcare fund, and it's a blast. And then connection to our portfolio companies. So now we've got 48, I think, someone's going to correct me, 48 active healthcare investments. Wow. So what's been great is the peer-to-peer support that our companies are giving to each other.
One of the reasons that I created this podcast was to sort of ask the rhetorical or the cheeky question is, can Silicon Valley save healthcare? Which implies that healthcare needs saving. And you've done a lot of process improvement work. You brought up Don Berwick. What's your answer to the question of, is healthcare broken?
It's broken. I mean, and what do I mean by that? So, it's one of these industries where I say that you have to really have lived in it to appreciate how complex it is. Like, it's a little bit, I've never tried to, go into aerospace, in my spare time and observe it from a distance, but observing healthcare from a distance is very difficult. Mm-hmm. So now both of us, Adam, are 30 years in, and we've seen some things. And what we basically have is all the things people know. We have misaligned incentives. We have a cottage industry. So this is really a cottage industry. You have a bunch of individual practitioners. Now, I'm not just talking about the individual docs, but even the individual health systems, where every single group in healthcare is working independently. And even within those groups are working independently. So you don't have a consistent, process set. This has not been standardized in any way, shape, or form. And so, I'll answer the question by going actually back to my staff model, which was one of the purest forms, in my opinion, of how you can align healthcare and how you can take away the broken and inefficient pieces. And so what I mean by that is, in that case, 1 million members that we had a consistent benefit package. So that's one thing that's broken, is people walking around today, each and every one of us has slightly different insurance packages, and different things are covered. And sometimes they're based on efficacy of what should be covered, and sometimes they are not. When you're in a staff model HMO where you're now responsible for those 1 million members and all their expenses, you think about all that very deliberately. Like, what should be in the coverage? What should be the health maintenance package? How do we be proactive with our population? So one part of broken is different benefit package. Second part of broken is different processes. So it's very random. The care that's delivered is, again, somewhere sitting in somebody's institution is a clear idea of the best and most efficient way to treat a certain type of cancer, to treat a hip replacement, to take care of people with chronic conditions. And those known processes that have the efficacy, cost, quality, efficacy, are not consistently applied. So if you have 15 patients, enter a doctor's office, they could be treated 15 different ways, right? So you don't have the process controls. And you don't have any way to create that standardization. And then that's all the care delivery side. Then we've got the administrative side, which is just wholly inefficient in so many ways. And because the insurance companies, it's really hard to really apply beautiful, clinical processes. They apply speed bumps and things like prior authorizations. They apply sort of these very awkward, non-value added often processes to try to gain control over what's happening. So this is extraordinarily hard to fix, and different than the staff model HMO, where we had aligned incentives, meaning we paid all of the expenses, so we figured out the most efficient and effective way. As you know, the majority of doctors are still fee for service, and so they are not thinking holistically. They're just getting paid for whatever care that they delivered without any regard for quality, no matter how much time has been spent on trying to get quality care out there.
With that as a background or a foundation of the problems, can this thing that gets wrapped up in what we'll call Silicon Valley, this sort of entrepreneur, venture capital, joint venture, if you will, can it actually provide solutions to the problem? And if so, where is its strong points? Where is weak points? And how much work do you think really has been effective?
Yeah, it's a great question. I will just start by saying, and I'm not sure Silicon Valley is the right geography to be pointing to. I would say New York, where we're based, and other places. But meaning there's a lot of venture capital being spent in healthcare, And it's been ebbing and flowing for as long as I can remember. And there is this great concept of, doing well by doing good, which is, can those of us who are really interested in fundamentally changing the trajectory of healthcare use venture-backed companies to do that. And I guess you would guess, I am a big proponent of it. So, and the reason I'm a big proponent is because I came out of nonprofit, and quite honestly, I wasn't, this is a generalization, but I wasn't excited about the ability of the nonprofit institutions that I worked in to really be innovative and to really think differently than their traditional legacy point of view. And so when we began to think, and when I started in healthcare, coming out of graduate school, no one went into healthcare. Right. Everyone went into banking. They went to other things. They're like, what does that even mean to go into healthcare? So we have now, as a result of the venture money and the mission, have attracted some of the best and the brightest to come out of their institutions or come out of their colleges and to think about healthcare as the problem that they want to solve. This is like incredibly almost emotional to me because we just didn't have this kind of talent coming into, and when I say talent, it can be individuals, but it could also be Google. It could also be, it could also be a lot of the sort of Silicon Valley companies thinking about how to really impact what we're doing. We'll get into this some more later, but it's really the venture backing that has made many areas sexy to focus on, meaning big mission and big opportunity for change and lots of money available, like Medicaid. So I think we've got some great examples of new delivery system models being created, people taking advantage of really understanding how to care for populations like new MA plans and overlay plans, and incredible innovation around the use of tech in all of these areas. So I think it's been a net positive. There's always examples of people who don't really understand. I get pitched every day. People who think they've discovered a healthcare problem are probably wrong. We know what all the problems are. It's really fundamentally how you fix them, and you still have to live within this legacy world that we of payers and providers in order to affect change, and that's not simple.
I don't know if you meant to do it, but you linked sort of the tax status of certain organizations with not an inability, but a slowness or a lack of desire to innovate. Did you mean to do that? Is there something about not-for-profit healthcare that stymies innovation? That if we just flipped the switch and said tomorrow all not-for-profit health systems, with the exception of somebody that needs an exception, would be for-profit?
Yeah, no. I definitely did make that connection because there's been. I think really the right connection is. Institutions tend to be who you are, meaning if you're a hospital and your entire orientation has been filling beds and your entire economics are around filling beds, then you will continue to fill beds. So people are fundamentally who they are. And I remember thinking, I guess when I was much younger, you'd be like, what is wrong with those folks? And then you realize they're doing exactly what they're paid to do. Exactly what they're paid to do. And in order to come in and to disrupt yourself, to say we're going to stop filling beds and we're going to instead do something else, it's hard. It's literally hard. Like, it's hard to do. It's hard economically to do. So you and I both, Adam, have probably lived through all the different variations on the theme of the creation of integrated delivery systems and buying up physician practices and doing all these things. But I think what I would say, which is a more complicated concept, is everything has to align, meaning you can't just change the for-profit to not-for-profit or vice versa, and then change the mission and do it. You have to figure out the economics. You have to figure out how you get through the transition without dying financially. You have to figure out how to serve your base, and it's complicated, and it's so complicated that we, for the most part, in our investment, have decided to create new delivery systems versus trying to transform existing delivery systems because it's been that difficult, not because these are not talented people, it's because they have a different sort of orientation. Yeah,
it's interesting. A lot of these new payer-provider partnerships in sort of the Medicaid and the Medicare Advantage space is been incredibly interesting. And getting back to the staff model that you worked in initially, where incentives really are aligned, I guess the question becomes is the hospital, the physical building, the physical company that is a hospital is still the epicenter of most of what happens in healthcare, and it still has an exceedingly tight grip on the status quo. And, it's very hard to disrupt the hospital business. I think we're starting to see it a little bit in, companies that like Dispatch Health and others that are bringing hospital level care to the home. But that's just, to me, it seems like a huge leap to assume that until we disrupt the hospital business, all these other things are just sort of nibbling around the edges. I'm curious how you would respond to that.
Well, I don't see the hospital as the epicenter. I think it's physically big. And I think I purposely have chosen to spend my career outside of the hospital in terms of my investment, meaning that, so I was always ambulatory. Right. I was always primary care. So your primary care doctor, particularly in a staff model, they're the ones who are the architects of the care that you're going to get delivered. And they're the ones who are going to make all the decisions. If they're proactively managing you, like they have a point of view about Adam and about who he is and about what care he should get. And as things come up, the most efficient and effective way to get you treatment, what that treatment should be. That's how people think when they have these aligned incentives and they own 100% of your care and 100% of the cost. I remember the first time I went to a hospital, and I was a little bit on the technology side, and I discovered that they actually purge records after a while. Meaning they don't have a view. They don't think of a patient as something they own. It's transactional, and again, I'm generalizing. So people listening might have, but you go in and you're in there for a transaction. All right. You're getting you're getting something done to you and then you're leaving. Okay. They're not there holistically managing you. So I, in fact, saw them as a cost center. In our world, we didn't have hospitals as part of our equation because we wanted to flex it up and down. We didn't want it to work against us and back then I think, average length of stay for a hip replacement was like 8 days, And so we are the ones that did all the sentinel work on saying what happens during this time and why is it 8 days and why the way it should only be 3 days and what keeps us from getting from 8 to 3. So that's how we really think about the hospital. And over time, you want to be able to ratchet down the number of beds they need to add and find alternative ways to treat patients. And I think we've seen a lot of that. The shifting of care from inpatient to outpatient to home, particularly post-COVID, has been remarkable.
I want to touch on something that you said in terms of venture capital, bringing the best and the brightest out. There's been a lot of people that have tried to go, and I'll just sort of paint with a broad brush too, and say the digital health route and try to bring solutions to healthcare. And there are a lot of companies that have died in the process. How do you work with your portfolio companies? When I came to Syllable, I was the first employee that had any true professional health system experience. Everybody else had been a patient and so had experienced healthcare, but nobody had any professional health system experience. And that I thought that was unique, but 2.5 or 3 years in, I'm realizing most companies start without, a professional health system experience. So what are the types of things that you help your portfolio company leadership appreciate and help them get over a hump that otherwise would strand other companies or other people?
No, it is a great question, and I actually lived it. I guess enough time has passed since I was at Athena that I can talk about it. But Athena was really a company that believed back when it was started that smart people could do anything. So they didn't want to pull from healthcare. I'm generalizing, of course. They didn't want to pull from healthcare because there was a belief that one is we have to undo the thinking of these folks. Like, look what they've created. It's not, terribly innovative. And so we didn't want them near us. But to your point, there's a lot of things. We live, no matter what we do, no matter what venture-backed company this is in healthcare, we're living within an ecosystem that is a healthcare ecosystem. And there are things we can't avoid. Some things there's just no way around it. So, the winning model, which one that clearly Syllable found in bringing you on, is taking the best and the brightest from these other industries, whether it be tech or whether it be, consumerism or whatever it may be, and then getting folks who really understand healthcare, but of course are not folks who can who are stuck in the ways of thinking about it. But and so the kinds of things we walk in sometimes to companies that don't understand the concept of corporate practice of medicine.
Right.
They don't understand, like these claims, these medical claims, they're so burdensome. Like, why don't we just get rid of them? And I'm like, the idea of getting rid of them is not a new idea. Like, what
right.
it takes to get rid of them is really complicated. The ability to sign up 100,000 independent primary care docs to distribute or to use your product, change any kind of change that you're asking. And you always get some early adopters who will tell you that you're brilliant and they love what you're doing, but you have to really understand, one, how do you live within the parameters that exist that have to be adhered to? How do you affect change across a lot of people who have a lot of reasons not to want to change? How do you deal with the fact that many of the new companies that we're bringing forward are going to replace staff in these institutions? We dealt with this at Athena. And what we really wanted to do is get people used to the idea that the people they're paying should be used at their sort of highest value, right, and not doing a lot of manual tasks. And so really getting people to understand that. So the perfect combination is healthcare experienced people, along with the really, particularly I think the experience in tech. And then the tech folks need to listen, which they don't always do. I mean, they really have often this attitude of like, you stupid healthcare people, like, what is wrong with you? And what they don't realize, I obviously don't say it just like that, but sometimes you get this attitude of like, trying to be polite here. Yeah, sometimes they do. And, I often will say, like, I'm not telling you this is good that you have to do this. We have a brand new MA plan, we have called Devoted. And, and they have to, no matter how innovative and amazing they are, they still have to live within the STARS rating. You still have to do the things that are required of you, even if with everything you have, that there's probably a better way to do it. So, yeah, so it's kind of that nice hybrid.
So we don't get very many callers into the show, but my mom just called and said, thanks for calling me best and brightest, because nobody's ever done that before. So
tell her, no problem.
So let's pivot for a minute. At some point in time in our lives, we either have been or will be patients. Is there a notable patient experience that you have had that has had an impact?
Yeah, this is an interesting question because so many people that come to us, that's their inspiration for starting their company. Whether it's my kidney care company or women's health company, or they've all had these experiences. So I have a positive and a negative. So my positive is I was a member at this staff model HMO. I'm still at, it's sort of a different version of it. We won't get into that, but I'm still a member, and so is my 20-year-old daughter. We have this wonderful experience now. They're so holistic that no matter what our issue is, whether it was, COVID, how many people came up to you and were like, what do I do? Like, who do I call? How do I get a test? You're like, and they didn't understand the purpose of primary care. So we have this wonderful experience where everything we need comes through one phone call into our health system here. And thanks to COVID now, it's very virtual and very efficient and effective and coordinated and thoughtful. Like, it's everything you would want. I have access. I have great points of view and sort of a holistic approach to my care. So that and that's not the norm. Like, I came out of this proactive primary care, personally, and I think I was, as I've stated, very disappointed in the fact that most primary care is not delivered that way. It's very transactional. No one's proactive. They don't really have a point of view about populations. They have a point of view about, you're sitting in front of me, I'm going to do these things to you. And then I think I've been through a lot. I'm now at the other side of, at least two sets of parents having been sick and passed away. My husband sick and passed away. And so we went through these experiences that, as a professional, I would sit there and say, I am like a professional healthcare person and I cannot figure out these systems. So there are a lot of, and again, there's so many examples, but I remember contacting one of my friends who was very high-ranking CMS person, and sitting in a top star rated nursing home that was the most horrific place I'd ever been, and saying, how is it that they have all the, we're viewing it from a distance with this great star ratings, and the reality is how bad it is. And dealing with other processes, which again, it would take the whole podcast for me to get into, but and also probably the world that you live in also, Adam, where we still have friends calling every day, having us get them into McLean's Hospital or Sloan Kettering or wherever. So this access to care is still a huge problem. So all of these things, every day I'm living it, we're all living it. And every day I'm like, I'm 30 years in, and we're still dealing with this level of complexity, in healthcare.
Yeah, it's interesting. Kobus used to ask when he would give a presentation to senior leaders, he would say, how many of you would allow your mother to come into your emergency room and get admitted to the hospital without making a phone call to the emergency room to let them know that the CXO's, mother's on the way? Nobody bites, and nobody will do that. I had another guest on the podcast who sort of talked about this access and navigation and complication problem that you just described as it's a competence, and we should teach our kids, very much like some people would say, well, you need to teach them basic accounting so they can balance a checkbook, which they don't know what that is anymore. But, you get what I'm talking about, that, you need to learn a little bit about how do you access care, not just how do you pick up the phone and call, but what is your insurance? What does it mean? What does it cover? What doesn't it cover? What's the difference between a copay and a coinsurance? I mean, these are all things that bedevil people that, as you said, have worked in it for 30 years. It's frustrating. It really is, because it just seems to get more complicated. I think, when we have open enrollment at Syllable, Kobus and I sit and forget the fact that every year we're getting double-digit increases in the premium, but there's subtle tweaks to the benefit plan, and then we have to sort of explain those tweaks to the employees who, they don't think about it until they absolutely need it. So if you're young and healthy, you're like, okay, what's the difference between a coinsurance and copay? But if you're having a baby, or you end up, getting thrown off your bike and breaking your collarbone and ending up in the emergency room, all of a sudden a coinsurance and a copay means something to you. And it really is something that most people have no experience with.
And they all cause friction. And I don't know about, the listeners or about you, but the folks in my life who needed care the most didn't have tolerance for friction. So I would get them teed up to, and I see this, we have opioid use disorder clinics, and we have a lot of mental health clinics or service offerings. And when someone finally decides I want help, and then they hit friction, either can't get into a clinic, or they don't know if the insurance is paying for it, or like what, all of the details, they then opt out. So these are all real. Besides being annoying and difficult, people are not getting the care that they need. And then, we, as well as probably many people listening, have the ability to just pay for care if we have to. I have that, right. I had a family member who's getting mental health, all of it was covered, and then suddenly the same provider, same benefit package, same insurance company, they just stopped covering for this provider. No idea why. And so for most people, they would have to have just stopped care. They wouldn't have any access, and you couldn't get an answer from the insurance company as to why, even though nothing changed, they stopped covering this. And it's very frustrating.
Yeah, and I can't think of any other experience in our life that provides that much friction. It's not reproducible. It's not consistent. It's like one day it's one thing, and another day it's this on Tuesdays, XYZ insurance company is going to reject claims for this procedure, and then the following day it's a different procedure. And as the provider, whether you're trying to provide the care or you're the patient trying to receive the care, you're absolutely right. It has a huge impact on adherence, and Lord knows how many disorders are left unaddressed because people just get tired and fatigued from it. Based on these experiences that you've had and that you've seen family members have, and your social circuit, does any of this impact the investment decisions that you make, or the investment decisions that Oak as a larger organization may make? Do you internalize these in the decisions that you make, or is it just completely more objective than that?
Oh, no. I mean, no, we're very mission driven. So we're going after things that have the largest impact on cost and quality. and the things that are sort of undeniably opportunities are undeniably broken. I think a great example, and ones that where nothing but goodness happens. That's what I like to say. So one of our early investments was a company called Aspire, which was an end-of-life palliative care company. And this was a great example of everyone wins when palliative care is applied properly. And it was just a matter of it's also one of the things I also love is when you don't disrupt the existing relationship, meaning primary care docs don't. There are certain things that at an end of a 7-minute visit you don't want to hear, right? Or you don't want to have to get into. It's just too much. Usually any kind of mental health issues, anything to do with substance abuse and end-of-life discussions is in that category. It's a very, very difficult thing, and people who are trained are really wonderful at it. And so if you can leave people home and give them dignity and make sure that they're not using services unnecessarily, which they shouldn't want to have anyway, no one wants to go through that. So these are the kinds of things that, where we either see opportunities where in many cases someone has created a methodology that is so compelling, like in this case, and they just haven't figured out how to scale it and how to get margin out of it. So that's really where we come in. We have other categories like kidney care. I mean, people who are nerds like us probably remember the first time we ever heard about kidney care and how that was all reimbursed, and the relationships that existed, and just dialysis. Anyone who's had a family member in dialysis, well, it doesn't take much to then, dedicate your life to trying to figure out how to keep people out of dialysis.
Right.
And then you have dialysis during COVID. So there are things like that where we are so passionate about the problem and the opportunity that we would even have considered starting our own companies, within Oak to serve those. Then you'll also see things where, again, I'm a big believer in you have to go 360 degrees around these problems. You cannot fix the medical problems that we have without fixing mental health. You can't fix medical problems without dealing with social determinants of health. So we've been really trying to make sure that we don't just take one piece of a process and fix it only to have weakness, on the other end of the processes. So yes, this has a, we are absolutely dedicated to these undeniable problems. Again, ones that are not the Republican or Democratic view. They are, absolutely bipartisan. They're not related to stroke of the pen, change in government, and ones that'll be sort of sustainable. That the impact will be sustainable and lasting.
So I'm so happy you brought up the social determinants of health. Because one of the many things that primary care physicians and sometimes other physicians are being asked to do are an increasing number of screening evaluations for a whole host of things. Screening for behaviors, screening for adverse childhood outcomes, screening for depression, and now people are screening for the social determinants of health. Nobody ever taught me about the social determinants of health in medical school. And if they did, it was probably, a 30-second comment of, and oh, by the way, your social situation can impact your health. Nobody told us how to deal with them and how to treat them. So are the social determinants of health, in your opinion, healthcare's problems to solve? Or is it even their problem to screen for? Or something else?
Well, so we'll go back to my staff model. So we didn't call it SDOH then. I think we called it things like housing and food and
what it was. Right.
But we had, what it was. We had this world where it didn't take much to realize that the environment that that our patients were in had an impact on their health. And so and as we've already established, we were 100% responsible for all costs. So if we're responsible for all costs and we think that the environment that folks are living in is having an adverse, reaction or impact on someone's health, then we did get involved. We would get involved. So that's, again, these aligned incentives. You get these incentives right, and then everything else falls into place. So so I'll tell you how we think about it more broadly, because not everyone's Kaiser and or Harvard Community Health Plan. So we're invested in a company called Unite Us, and Unite Us is a remarkable company in that they're a platform that brings together supply and demand for social determinants of health. So if you think about their mission is to find people who have housing, food, transportation, and mental health, and they have like 270 different types of services. People who someone's identified that they need these things, and then connecting them to the community, mostly community organizations, to get them. And this is like the terminal end of the terminal end. This is really, really difficult. And I think even my daughter in like middle school did this exercise where they're like, you're a mom, a single mom, and you need to get housing and food and all these things, and then showed them what it was like. You have to go to different departments with pieces of paper across town on the bus, and it's just a nightmare. So in a world where we want people to get these things, where someone's already actually determined that they'll pay for these, we make it incredibly difficult and inefficient to get them, and incredibly difficult and inefficient to see which ones of these service companies are actually any good. Some of them are handing out moldy food. Some of them are doing getting housing in 29 days, and some are getting them in 2 days. So Unitas created a platform that brought together supply and demand, and then also is on the path to doing a whole bunch of things that you have to do in the 360 degrees around, using data to understand which of these things, some of these things have a direct impact on medical. And then to your question, if they do, then yes, healthcare should play a role in helping close these. Whether they pay for it directly or they make sure that you get access to services that are covered by someone else, it's in their best interest to do that. You have to go to where people are. You've heard this before. We can't right. We can't bring people to the way that we want to live, because that's how we think is important. We've got to go to where they are and make sure we help them continue to live the lives they want to live, but just with a little bit more ease and grace.
It's heartening to see that we are still struggling with these things, but there's a little bit of enlightenment, I think, that has occurred, and the recognition that the people that we're serving, patients, really do deserve a voice and have a voice. And I see a lot of the energy within the digital health space as a result of that people recognize that the consumer experience is broken, to what we talked about earlier, and that only by engaging the people that are actually getting the care are we actually going to develop solutions that work for people.
Yeah, and it goes full cycle to your first question around Silicon Valley and investing. And I think managed Medicaid is one of these just amazing examples. I always say it was one of the best things that happened. I attribute it back to the Obama administration when they extended Medicaid, and suddenly people woke up to millions of managed Medicaid members, and suddenly realizing they didn't really know the population and how to affect it. And all of these companies, because so much money goes into Medicaid, because whatever you spend comes back, comes back to you. A lot of companies have been born to focus on managed Medicaid, and it is the best thing ever that we have figured out how to make it something that's super attractive, that at the end of it, an entrepreneur can say, wow, I made a huge difference with a population that has not been focused on, that people will often say to you, like, too complicated, too hard.
Right.
And at the end of it, we will have all these great examples of improvements to that population, I think, as a result of venture backing.
So you may have just stolen the thunder from my last question, but we're coming to the end of our time together. And I was going to ask you which one of your investments are your favorite, but then when you likened it to your children, it's like asking you which child you like the best. And I'm not going to ask you that. But so what excites you about either the investments that you have now, or sort of where you see the next 6 to 12 or 18 months? What's got you excited about what you're doing?
Oh my gosh. Well, first of all, I have like the best job. I don't care who's listening. I have the best job. And that's because I get to work with these entrepreneurs. I mean, it's a privilege, including the folks at Syllable. It's just a privilege. And so it's again, I cannot say enough how amazed I am at the talent that's come into this little field of mine called healthcare. And so I think what's been really exciting is seeing the evolution over the last 8 years of our companies. And a lot of them are primary care, but a lot of them are also virtual first, digital. And what that means is they're really thinking about the consumer and letting them sort of be in their natural habitat, meaning nobody wants to get up and go to the doctor or have to seek care in the sort of traditional ways. And so what we've done is we've created a lot of companies that are overlays to the existing health systems. So like Maven Clinic, which sits over the top of, infertility, fertility, maternity, parenting, and provides this 7 by 24 hour support to get access to information and get access to caregivers, get support, get your questions answered. Just amazing. So what's exciting to me is these models, thanks to COVID, like weird, wish it didn't happen, but silver lining, thanks to COVID, people are now recognizing that not just transactional care, like getting urgent care visits, but that actually getting day-to-day care and getting day-to-day support can be done virtually. And so we are now finally seeing a fundamental change. Things like Maven being part of a maternity benefit now, really coming up with these, it's coming up with contemporary, this is the way we deal with everything else in our lives, contemporary ways to access care. And then the other thing that's been exciting is the number of direct-to-consumer and then turned medical companies that are out there that are, we work with a number of companies that were born and gone directly, like Cerebral and Noom and others going directly to consumers, and seeing again that we're finding new ways to provide access to care that scales like bricks and mortars just didn't. So I think, and then I had to say the tech. Your company is a great example of this. I didn't think I would live long enough to actually see, tech finally get us to the point where we could drive efficiencies and move data. We can actually move data now and interoperate in a way that's, in a way that I hope I don't have to think about interoperating anymore. I can just think about use cases, So this is a super exciting time. I think the United States eyes have been sort of wide open, or now they're wide open from seeing what we did with COVID, and the tech is here and the talent's here, and it's a great time to be doing what I do for a living.